Hello, everybody, and thank you for joining me again on the monthly clinical review. This month's topic is myoclonic seizures. Remember, these are topics you've submitted, and we've chosen to review here for your additional professional development. This is also part of APS503. As we go through this, these will be part of your monthly grand rounds, and you can also use this towards any CME that you may need for the year. This is going to be a fairly short and concise review of myoclonic seizures and should be approximately 20 minutes. If you have any questions, please feel free to reach out and contact me afterwards. I'd be more than happy to answer any of those questions you may have. All right, so the pathology here. A seizure, as we all know, is a brief temporary disturbance in the electrical activity of the brain, and it may affect muscle control, movement, speech, vision, eye movement, awareness, behavior. It works with the GABA and glutamate as either an excitatory or an inhibitory type of an actions. Specifically, our review for this for the rest of the remainder of this little review here is going to be myoclonic seizures. Now, these are specific muscle spasms in generally select muscle groups or could be across the body. These are caused, and we're going to go over why these are caused and how we are going to work with these. There's three main pathologies here that are important that these patients, if you ever come across these patients, will most likely be previously diagnosed. The first one is juvenile myoclonic epilepsy. And this is the most common generalized epilepsy syndrome that you'll see with myoclonus involved. It may also be called, or you may be referred to as epilepsy of Jans. It's first seen in adolescence, even though it's called juvenile. It can, but is less common to development in children in their preteen years. These patients generally also have tonic-clonic seizures and sometimes some absent seizures, and this is predominantly where the danger or the concern comes from. It's not necessarily the monoclonic seizures that there's going to be concerns with. The second pathology, progressive myoclonic epilepsy. Now, this is sort of a group of genetic neurodegenerative diseases that are associated with spontaneous action-induced myoclonus and progressive neurological deterioration. So we're talking here about progressive cognitive decline. Unfortunately, these patients may start off with regular developmental regular development, and then unfortunately they decline over time. That turns into some ataxia. They may develop, again, something neuropathically, and then obviously because of the ongoing situation here, some myopathy will develop over time. Now, as mentioned, the myoclonic seizures are the core feature here. But it's the tonic-clonic seizures that will actually be more problematic in these situations. The last one, epilepsy with myoclonic atonic seizures, is a very specific epilepsy. Now, this affects young children again, generally between 7 months to 6 years. It has a 2-to-1 male to female ratio, and it has, again, multiple generalized seizure types will be more involved with this. These particular patients, once they're diagnosed with that, you will have to watch out for status epilepticus, as it becomes quite common later on as the disease progresses. Now, during this review, we're going to talk numerous different ways about classification and seizure types. It's important to understand, generally speaking, there's multiple different ways to categorize and classify and describe seizure types. So the first part we're going to talk about is generally where they come from. So there's a focal onset, generalized onset, or we just don't know. So those focal epilepsies include unifocal or multifocal disorders, and they generally involve or do involve the one hemisphere. These can be seen as a focal awareness seizure or focal impaired awareness. And again, these are going to be generally picked up either as a very good clinician can watch this happen, or they are confirmed by then a diagnosis with an EEG, confirmed by waveforms. The generalized onset may not be able to be pinpointed exactly where in the brain, so it's a generalization of that area. And again, these have the same sort of range of types of seizures, again, as we start to classify them as absence, myoclonic, atonic, tonic, or tonic-clonic. Again, this diagnosis is made on a clinical grounds, and again, supported by EEG readings. Those are the electrodes hooked up to the brain or to the scalp, and then they can be tracked, much like we track the ECG on the cardiac monitor. So these, and then an unknown onset here. So these are the ones where we don't know. Either there isn't enough data or it's too early on in the diagnosis that we haven't been able to get any data. Now these are generally going to be diagnosed, well above our range, and probably not even in an ER. These will be done by a neurologist, after quite some follow-up. Other seizure types, no, these are the specific sort of what we see as the seizures. These seizure types include absence, which is just no seizure activity observed. Myoclonic, which is what we're going to be talking about, is the single muscle jerking. Atonic, which is no muscle tone whatsoever. The patient may go limp. Tonic is a spasm contraction of the muscle. And then a tonic-clonic is the I guess is more of the spasmodic, tonic, and then the release, and then tonic again. So these are the ones that have full body, generally fully unconscious. These are the typical diabetic seizures or the true epilepsy seizures I've seen in TV, and I'm sure everyone has seen those in their own experience. Now, specifically then again for the myoclonus classification, they want to get into more depth with this, so it becomes again a focal, multifocal, segmented now because we're looking at a different area or different types of seizure classifications here, are generalized again. And they also specifically try classifying it by provoking factors. So it can be a spontaneous or a reflex. And what that means is if somebody's gone on and sitting there and they're all of a sudden just have this myoclonus jerk, that would be a spontaneous one, versus a reflex, and we'll talk about some of those coming up. Whereas if somebody were to scare them from behind, or a bright light, or some sort of an impulse has set that one off. The three, again, a different classification of where these specific myoclonus issues are coming from, are the cortical, subcortical, spinal, and peripheral. The big ticket items here are going to be the cortical, which is your cerebellum, or the subcortical, which is your brain stem. Spinal is self-explanatory, and peripheral generally actually deals with more of the peripheral nerves and such outside of the actual main CNS, if you will. There's other ways to classify them as well. So they talk about physiological. So these are your muscle jerks under very specific circumstances. So again, just an arm jerking. These could be full torso. Essential myoclonus actually has no neurological deficits with this. So you need to be able to determine if there's any sort of a post-ictal phase with this, or if there's nothing else happening. Myoclonus of epilepsy is, again, true epilepsy. However, our true response is what we typically see or are called for is the tonic-clonic or full-body seizure. These may be just a very minor myoclonic jerks are the only seizures witnessed during these patients. Now, they are, again, potentially at decreased GCS, and still as much danger going on, but their form of seizure, their muscle activity is just this myoclonic. And then we talked about symptomatic myoclonus, or we will talk about symptomatic myoclonus, which is known neurological diseases. So this is something more along the lines of MS or Parkinsonian type disorders. Now again, here's another chart. I did not create this. I did borrow this. But this gives us, again, just a bit of an overall top-end view of different classifications for myoclonus, which way you want to think of it. You can mind map each one of these from a clinical, pathophysiological, and etiological format. You can take this internally in any which way that you want to do this. Is the best way you can do this. We want to look at other causes here real quick too. There's a boatload of drugs that cause this, and these are true, not necessarily differential diagnosis, but other causes of these myoclonus tics or seizures that we're going to see. And we see a list here of toxicological or toxic causes as well. So depending on where you work, some of these may be more prevalent than others, but these are things to others causes to be aware of when you see these myoclonic patients. Now, truly getting to the differential diagnoses then, we want to make sure that we look at all of these things. So is this reported to us as just being a myoclonic type seizure, but did they have any other type seizure activity before this was witnessed, whether by us or by bystanders? Was there any syncope, either predominantly before this or during this sort of a thing? Was the syncope what caused these sort of jerk-like reactions? We want to make sure and check out this cardiac reflex syndrome to make sure there's no other neurogenic issues, whether they are orthostatic or psychogenetic. You can have panic attacks fall into there, TIAs, strokes, Parkinson's early onset, migraines, global amnesia, movement disorders, myoclonus paroxysmal dyskinesia, sleep disorders, parasomnias, narcolepsy, REM, not the band, the rapid eye movement behavior disorders, and again, as mentioned, multiple sclerosis or other neurodegenerative diseases. Okay, so these are things we need to keep in mind. We only get the report or witness ourselves this myoclonic type activity, but we just want to make sure that we're thinking of everything else. Specifically for the myoclonus, what we're looking for is, again, this single limb jerk. We're not talking a multiple, repeatable situation. This may just be somebody walking down the street and the arm whips out. There's videos on YouTube, maybe you've never seen one of these before in your own clinical practice, where it's literally somebody's just sitting there, they're drawing something, and their hand all of a sudden jerks across the page, and they spill their drink, or they write a big line across their page. So that's what sort of these things are looking for. These are what we're looking at. It's important here, I've added this to know where, or to start to beginning to think where some of these instigators are from. So again, the cortical myoclonus are going to be jerks in the hand and the face. These are generally provoked by tactile stimulus. The subcortical or brainstem myoclonus jerks are more prominent in the axial region and the proximal extremities. Okay, so they're going to be bigger, closer to the core type reactions. So you may not have the hand slip out, maybe just the elbow jerks back, or the shoulder jerks up, or something happens in the hip. You get some spinal myoclonus, which is a unilateral arrhythmic jerking in the arm or the trunk. You may, in this situation, get a repetitive jerking. And again, this is getting further and further away from the brain, per se, as it's moving down the CNS. Symptomatic myoclonus. This is where you actually have a little bit more brain involvement, where you're actually going to have a cognitive impairment, true epilepsy, you may have ataxia or other movement disorders, or again, some other neurological signs. Again, whether that patient has lost full consciousness or their GCS has become majorly altered. These are what we call symptomatic myoclonus. You can have acute or subacute onset, which you want to be aware of, thinking back of your overall history and your picture of your patient. These clinical features may be, I've never seen this is brand new for this patient, or this might be, he's been having these sorts of things every once in a while. It's been going on for a couple of months, every couple of weeks, something like this happens. So this leads you again thinking to several causes, potential toxic, metabolic, or infectious etiologies. Unfortunately, these things generally are all progressive. They're generally degenerative processes, and then they lead to other pathologies within themselves, as we talked about, some myopathies, some static encephalopathies, or some progressive metabolic diseases as well to be aware of. So when you arrive to these patients, whether you're doing a history, working up in an ER, from a critical care standpoint, so you're doing a transfer for somebody, or you've answering a 911 or emergency call, history here is very, very important, especially if this patient has never been diagnosed or doesn't have a diagnosis truly of what the symptoms or situation is. So we need to figure out what has led up to the seizures, especially if they're, again, not diagnosed, because we want to make sure that we add to their case, their file, what's been happening. So the age of onset, we're going to gather that from everything. So is this the first time this has happened? Obviously, how old is your patient? Is this the first time today? Has it happened before? How many times does it happen? Concurrent past medical histories, again, which may or may not help rule out differential diagnoses. The course of this pathology, it started 6 months ago. It was just his baby finger. Now it's worked up to his elbow. Again, the duration of the disease, months, days, weeks, years. Any family history that they're aware of. Precipitating factors, which may or may not be either known or admitted to at the time. But things to be aware of. Remember, we talked about all those drugs, or that other slide back a few pages there had the drugs that may be things. So if this is a child who, again, may or may not have the ability to answer some of our questions, the parents may not know about the drugs. If this is going to, again, a 911 situation or an emergency scene, trauma may be involved there. Stress generally has a longer or slower onset. So the stress may be building from work or personal events for days or weeks or even months at this point. Again, try to figure out a history. The patient may be able to tell you some of these things. Maybe this will be from bystanders. So are there triggers that the patient is aware of or bystanders noticed when this happened? Again, history about the body parts involved. Is it always the baby finger on the left hand, or is it his right arm, or does it move around the body? And then the sort of the nuance things, we want to make sure we can get a picture of the rhythmicity of the myoclonus. So is it the same motion every single time? Does the movement change or alter around the patient? Is it move from their fingers into their hands, into their wrist, into their elbow? Does it go from side to side, et cetera, et cetera? So we want to make sure that we have a good picture so that we can sort of feed that back on or into, again, as the patient's file or into the hospital to get that patient. Again, we're watching if we're seeing these patients, what they look like. So they're going to be these jerks in their arms. They're uncontrolled, where and when this is happening. So we may need a minute count. We may have the patient tell us it happens a couple times every hour, every year. We may not be able to count that ourselves, but we want to be able to do that. Time of day would also be a when. Maybe this is an early morning or a late night thing when the patient is sleeping. Maybe there's been some other stimulus in that environment that's been going on causing these sort of things. There's an actually pretty cool, or very, very up-to-date computer AI program that has been developed that by taking a video recording of a patient in any sense of their seizure activity, it has a very, very high rate of being able to properly diagnose this prior to any sort of imaging ongoing, just from this computer AI stuff. As part of the physical exam, I added up here a YouTube video, which I highly suggest everyone go and see. It's not noted here properly for bibliography purposes, but I do want everyone to go and type this in here. I found the video somewhat entertaining. It was put on, I believe, by the United Kingdom. What I found the most interesting, though, was the actual comments following it. It was a number of patients who had experienced myoclonus seizures and epilepsy, and they talked about a lot of things which really just brought to light what we're looking for in a physical exam and how to deal with these patients. These patients shared a lot of their stress with the disease, sharing stories from their parents, their friends and family, and even their physicians and healthcare professionals not believing them, thinking they were acting out in school for some of these things. They would be making jerk motions and acting up in class or getting in trouble at school or hitting students. So these are things that made their ability to advocate for their concern. They had to fight that this was a real problem for them. Another issue that a lot of these patients or these people posted on these comments were actually the injuries they had suffered while going through some of these things. So whether they had spilled boiling water on themselves or banging their head on something while they were moving around. Somebody had cut or stabbed themselves with an object while they had it in their hand, and they wouldn't normally have hurt themselves, but the sudden motion happened to be doing that, and they couldn't control it. So It was a bit of an eye-opener, and just from a clinical standpoint, interesting to see the observations and the feelings of the patients themselves in a more wide context than a one-on-one, or even in my career I'd be able to get. Treatment for these patients. So the myoclonus itself is really not what we're here to treat. Overall, in an acute phase, it's unlikely that we as paramedics would be needing to start a treatment for this. But it is important to understand that there are obviously pharmacological treatments available for these patients. So valproic acid is probably the number one out there. And then there are these other medications here, which I won't even attempt to incorrectly embarrass myself by saying them. It's very important throughout this that we understand where the stimulus is coming, from, whether it be a cortical myoclonus or a subcortical. The treatment may be maybe detrimental if we treat the patients wrong. The spinal subcortical really only has this medication here, the levetiracetam. It's the main one. So again, if you see patients on this, they'll probably be known to have this sort of a thing. Best case scenario is if we do need to be treating some of these patients in an acute setting, clonazepam does work and is the most helpful with all types of myoclonus, so it's safe for those. And then again, talking about certain classifications where we're seeing myoclonus, although it's truly not a neurological potentially issue, but still part of the CNS as you're focal or segmented. There are actually injections with Botox that has had variable success depending on them. And again, this is not to stop the seizures ongoing, but to stop more of a, again, Parkinsonian type ongoing seizure activity that becomes detrimental to their daily activities. Again, we want to make sure not only is it beneficial to know where it's coming from, because one drug may be beneficial in other cases, but specifically with myoclonic seizures, we want to avoid phenytonin and carbamazepine, as these can worsen the myoclonic seizures or absence seizures and instigate full-on epilepsy or tonic-clonic seizures again. Other treatments with this, again, these patients are probably not acute, generally not as long as it's just the myoclonus, not in any danger. But we want to make sure we've obviously assessed their ABCs. These patients should be treated as a potential seizure at any moment. So IO or IVs access, if there's any reversible causes that we can be treating. So again, checking your blood sugar, making sure it's not just a diabetic issue. And this again goes back to the comments of treating these secondary injuries, or which may in fact be the primary injuries in these situations. The myoclonus was the seizure that caused this little event. They didn't fall down. There's no neurological damage at this point. But the jerking motion flipped hot bacon grease into their arm or their face or somebody else, sort of a thing. So these are the things which we may be called to deal with. And again, this prepare, as mentioned, many of these myoclonic seizure activity can be in addition to or a precursor to full clonic tonic seizures. So we want to assess the airways, do your lemon scores if you do that where you're from. Get IVs, get some drugs up if you need to pre-draw some drugs as well. And be prepared that what you're going to do, get the patient on your stretcher as quickly as possible, and potentially prepare to intubate and ventilate the patient if they go down that route. Relevant investigations. So really it's our job to try to get as much done as we can. We want to make sure we can do as much as we can. So we want to get blood sugars, cardiac workup, and labs. If you guys have iStats or any other sort of labs that are there. If you're, again, picking up in a critical care setting and you're doing a transfer, you want to make sure your labs are up to date, the right patient, right time, all that jazz. Ultimately, these patients need to find their way to a neurologist and have a date with an EEG. Okay? There's another electronic testing called a polymyograph. The ECG explains or examines the electrical activity happening in the brain. The polymyograph, or the EMG, basically is, again, another electrical stimulus sensor for the actual conduction and movement or activity of those effective muscles. So this again is sort of a use on determining whether or not it is something happening in the brain, something happening in the nerves going to and from the muscles, or something happening within the muscle themselves. And again, the EMG helps with that, and that's the nerve conduction and the muscle use. They map that up. Ultimately, we want to make sure that if all of these things or none of these things have found anything substantial, then potential for brain imaging or spinal cord imaging. And you want to make sure that, or what we're looking for is that the structural or any focal lesions are identified. Generally, MRI, again, here's the imaging we're talking about. Depending on your unit, where you live, depending on the size of the city, you may have just a CT scan, which isn't ideal, may show a little bit, but probably not great. And you may have all the way up to a PET scan, which would be ideal, or new sophisticated technology like that. If after all of this, again, further down, certainly not we're getting into quite yet, but then we want to do, or the patient wants to have done some genetic testing to ensure that this is something, or to see if there is something that they can clinically attach to from a genetic standpoint to know what's going on. Transport decision making. We need to make sure what we're doing with this patient and where we're taking them. Absolutely. If somebody has been concerned enough to call for our services, we should make every effort to make sure that we take them. The patient may be embarrassed, may not want to go, may feel like it's nothing at all, and we have to respect their options with that. But by having an open discussion with those patients about their concerns, our concerns, whoever called concerns originally, it never hurts to go for a checkup just to be sure. These sorts of issues are not one of those things that you can drive down the highway and get in a seizure, and usually things don't turn out that way. So you can always paint that picture for them if it's an issue trying to sell the patient to come to the hospital. These patients must seek a neuroconsult. So again, the tension or the stress of your patients, understanding that they may have to visit an ER several times with no definitive diagnosis, doesn't mean that every trip to the ER is not an important one. It again builds that case, builds their file for the neurologist to say this is on a repeating issue and it needs to be considered. If something is ongoing, obviously, we need to make sure that within all considerations is that we can transport the patient to a facility that has scanning and a neuro team on site. So again, if it's an option between two hospitals in the same city, then obviously go to the neuro center. And if you're out of town, it might be possible prior to go to your smaller town that you actually end up going to the bigger town. Obviously, if you have a local bypass on this, I would follow that as well. I included this jovial little cartoon down here because I think seizure patients are a little bit like TNT or nitroglycerin. The old shake them and they'll explode. I've always had a high regard and concern for these patients that with little or no warning, they can go off again and have a seizure. So whenever we're transporting these patients, I've always made it my goal to ensure that the patient is as comfortable as possible. The stimulation really is down. So I know it's impossible on the fixed wing, the helicopter, those are loud devices. But we may want to try to sedate those patients beforehand, with a little sedation. Just see what we can do to make sure. We want to, again, prepare for the worst and hope that we don't have to do anything. So again, all of these patients, regardless of a simple myoclonic jerk once today, will probably get an IV with me. Just, God forbid, that this is the day that they decide to go full tonic-clonic on us. So just that little picture there. Anytime you have a seizure patient, prepare for the worst. It's part of the leadership role. It's important for us to, again, I think I've sort of peppered this in here, but we want to make sure that we have a clear clinical picture before beginning treatment, as incorrect diagnosis and drugs can be very detrimental. It was a great review to make sure that reading those patients' comments on the YouTube page there really just sort of drove home that message that we can be advocates for these patients when they complain to us about these symptoms that they're suffering from. It's not for us to decide whether or not the patient is lying, but to take them at face value and assume that this is something that the patient has experienced. They're fearful, maybe a little bit concerned, obviously, and for us to make sure that we can help them to the best by just listening to them, believing them, and taking them where they need to go. We want to advocate for the patient and family about education, about the situation. So it's not so much just that we take them to the hospital. We can tell them what to make them, we can tell them things they can do, research things, et cetera, et cetera. And we want to have clear communication between the neurologist and the pharmacist to make sure there's no, or minimize the amount of drug errors that may happen. We want to take a team approach and support the patient's voice and their needs. Again, if the patient has concerns, you want to make sure that the ER triage nurse or whoever is receiving this patient hears those, and you can be their voice for them. And as well, the pediatric population here. If, as mentioned in those first couple of slides there, the three main pathologies here that are truly myoclonus in succinct order are going to be those pediatric patients. Maybe younger teens, but they still need some support. They'll be fearful potentially. We're wearing masks a lot, huge big helmets if you're on the helicopter. We could be scary people who are taking them away from their family if you can't transport them with them. So we need to keep that in consideration as well from a leadership standpoint, try to soften that and be as friendly as we can to our patients. All right. Thank you, everybody. I would like to finish up and wrap up. If you guys have any questions, please feel free to contact me, and I will see you next month for our next program.